recent consensus guidelines recommend surgery for all patients with main duct intraductal papillary mucinous neoplasms, IPMNs, mucinous cystic neoplasms, MCNs, and any pancreatic cyst associated with high-risk stigmata and close non-operative surveillance for branch duct IPMNs. Even at experienced centers, however, surgical morbidity and mortality for pancreatic cystic neoplasms are in the range of 20 to 40% and up to 2% respectively. Although surgery of surveillance alone may be optimal management for most patients with PCNs, there has been increased interest in a minimally invasive therapeutic intervention termed pancreatic cyst ablation, PCA. This technique, which is performed under endoscopic ultrasound guidance, involves lavage of the neoplastic pancreatic cyst epithelium with ethanol and or Paclitaxel. Measurement of the clinical efficacy of PCA has been evaluated principally by the change in cyst size on follow-up imaging and histopathology following surgical resection. Following PCA, cyst resolution by cross-sectional imaging, defined as no visible residual cyst, ranges from 33 to 35% for ethanol lavage alone. Investigators in Korea reported that the addition of Paclitaxel at a concentration of 3 to 6 milliliter to ethanol lavage improves cyst resolution to a range of 60 to 79%. However, the histological correlation of cyst resolution in these patients is generally unknown, as those with a dramatic decrease in cyst size after ablation are the least likely to undergo surgical resection. Thus, other non-surgical approaches may be helpful to assess the effectiveness of PCA. It's well known that pre-malignant pancreatic tumors and cysts demonstrate defined DNA mutations and deletions or chromosomal losses such as KRAS mutation, P53 overexpression, and loss of P16 and SMAD4. Detection of mutations such as KRAS in pancreatic cyst fluid by EUS-guided fine needle aspiration may permit more accurate characterization of their malignant potential and theoretically identify cysts that require close follow-up or surgical resection. Changes in cyst fluid mutations following cyst ablation are unknown. In their study entitled Alterations in Cyst Fluid Genetics following endoscopic ultrasound-guided pancreatic cyst ablation with ethanol and Paclitaxel, DeWitt et al. Aimed to evaluate changes in baseline pancreatic cyst fluid DNA following EUS-PCA with ethanol and Paclitaxel. They hypothesized that ablation of pancreatic cysts with ethanol and Paclitaxel would lead to elimination of mutant DNA. Their secondary aims were assessment of radiographic changes in cyst size after EUS-PCA, adverse events of EUS-PCA with ethanol and Paclitaxel, and histopathology in patients who underwent resection after EUS-PCA. Here's what they have to say. Background and study aims. Endoscopic ultrasound-guided ethanol lavage with Paclitaxel injection has been shown to be effective for the treatment of pancreatic cystic neoplasms. However, the evidence for effectiveness is based primarily on cyst resolution on imaging. The aim of the study was to evaluate changes in pancreatic cyst fluid DNA following EUS-guided pancreatic cyst ablation with ethanol and Paclitaxel. Patients and methods. In a single-center prospective study, patients with suspected benign pancreatic cysts 15 to 50 mm in diameter, 5 compartments, underwent EUS-PCA with ethanol and Paclitaxel, followed 3 months later by repeat EUS-FNA, cyst aspiration for repeat DNA analysis, and possible repeat EUS-PCA. Abdominal imaging was repeated 3 to 4 months and 12 months after the second EUS. Changes in baseline pancreatic cyst fluid DNA, procedural complications, and radiographic changes in cyst volume were evaluated. Results. A total of 22 patients, median age 67 years, 15 women, with cysts in the head or uncinate 10, body or neck 8, and tail 4, measuring a median diameter of 25 mm, range 15 to 43 mm, underwent 1 n equals 22 or 2 n equals 9 EUS-PCA procedures. Baseline cyst DNA included mutations in 11 patients, that is 50%. Post-ablation cyst fluid, n equals 19, showed elimination of all baseline mutations in 8 patients, new mutations in 3, and no changes in 8 without a baseline mutation. The largest per protocol post-ablation image-defined volume change, n equals 20, from either of the follow-up abdominal imaging studies, n equals 20, demonstrated complete response, less than 5% original volume in 10 patients, which is 50%, partial response, 50 to 25% of the original volume in 5 patients, that is 25% of the patients, and a persistent cyst greater than 25% of the original volume in 5 patients, which is again 25% of the patients. During a median follow-up of 27 months, range 17 to 42 months, adverse events from all EUS-PCAs, n equals 31, included abdominal pain alone in 4 patients, 13% of patients, pancreatitis in 3, 10% of patients, peritonitis in 1, 3%, and gastric wall cyst in 1, again 3%. The adverse events were classified as moderately severe in 4 patients, 3 with pancreatitis and 1 with peritonitis. Conclusion. EUS-PCA with ethanol on Paclitaxel may possibly eliminate mutant DNA in neoplastic pancreatic cysts. This technique leads to complete or partial image-defined resolution in 75% of cysts, but may lead to rare adverse events.